everybody to tonight's webinar. I'm Dr. Lena Nido. I'm the GP Liaison Officer at the Ionia Hospital. I think many of you who've been to our webinars before I've met. I'd like to welcome you tonight, and I'm going to be facilitating the webinar. So I'd like to acknowledge the people of the Kulin Nations who are the traditional custodians on the land that the webinar is being recorded on today. I'd also like to pay my respects to elders past, present and emerging, and to any Aboriginal people attending today. I'd like to acknowledge our speaker, Dr. Christopher Brown, who's generously donated his time and expertise to provide this presentation. I'd also like to thank the Northwest Melbourne PHN for partnering with us to provide this GP education event. We are very grateful also to the Collier Fund, who have generously donated a grant to assist us to fund our GP education program. Now, you all should be muted throughout our meeting, and in order to facilitate questions, I'm going to ask you to type your questions into the chat box, and I will be monitoring that and moderating those questions as we go. If they're very relevant to the slide that Dr. Brown is on, then I will interrupt him. Otherwise, I will leave the questions to the end. But please type your questions as you go so that you don't forget them. We are video recording this event, and I'll let you know when the video recording becomes available as a link from our Ionia Hospital website. Evaluation forms will be emailed to you at the close of this webinar by someone at the Northwest Melbourne PHN. Please complete them as soon as possible so that it's fresh in your mind and that it gets done. We do value your feedback and use that to plan our future events. Just very briefly, I'm going to show you some pictures of the Ionia Hospital website. Most of the relevant information for GPs is under health professionals, and then there's a box for GPs. But the COVID-19 updates are there on the front page. We have referral guidelines at the Ionia Hospital. They're broken down here. You can see, just open those to have a look at them. Our referral guidelines actually coincide or incorporate the statewide referral criteria, which have been developed by the Department of Health to try to create some continuity across public health services across Victoria. ENT statewide referral criteria came in 2 years ago, and the ophthalmology statewide referral criteria have been introduced this year. It's important to just be aware of that because all public hospitals are triaging against those criteria. And to make that easier for you, the statewide referral criteria have been incorporated into health pathways. So this is a screenshot of Melbourne health pathways. If you live in northwestern and eastern Melbourne, you will have access to these via your primary health network. For those in most of the rest of Victoria, or even in Victoria, sorry, there might be some people attending this webinar from interstate. So all of the criteria are actually for Victorian state hospitals, and there will be equivalent health pathways for other primary healthcare networks within Victoria. And they will all be consistent with the statewide referral criteria. I think a little bit later on, I explain how you can access health pathways if you don't already have access to them. But this is some pictures depicting the rhinosinusitis health pathways on the Melbourne health pathways. I'm not going to go into detail. Our speaker is going to go through most of the content, but just to show you that there is lots of information there. This is what pathways look like with red flags at the top, background information, and then you can work through it when you're actually seeing patients with information about assessment and management. So I've just opened up some of those drop-down boxes just to very briefly show you what they look like, but I won't go into the detail. I'm going to fly through that. But you can see there's so much information there. All of these little plus arrows, if you click on them, they open up and give you this detailed information, but you can close them again so that you can follow the pathway quite easily. Lots of information here about chronic rhinosinusitis and referral information. So generally for your area, the pathways have been localised if you access them through your local primary healthcare network, and that will link to localised referral pathways. So how can I get access? So you'll need a login. The best way to get your login is to contact your local primary healthcare network. If you don't know their contact details, then you can go to this website to get them. So just very briefly, I'm actually not going to go into the details of the learning objectives, but that's them there. I'm sure Dr. Chris Brown's going to cover that in great detail. It's my pleasure now to introduce our speaker, Dr. Christopher Brown. He's an otolaryngologist. He's an ENT surgeon with a special interest in adult nasal and sinus disorders. He completed his surgical training in Melbourne before completing a rhinology fellowship in the United States. He has presented at international conferences and published in peer-reviewed journals. He's actively involved in teaching and is the Victorian representative for the Australian and New Zealand Rhinology Society. He is a reviewer for the Australian Journal of General Practice and sits on several committees advocating positive outcomes for patients. He currently works in the rhinology clinic at the Royal Victorian Eye Hospital and also consults privately. So I think I'm going to stop sharing my screen now so he can share his. And I might mute myself too.
Thanks, Nina. So I'll just share my screen and say hello to everyone. Hopefully you can, Lena, can you see my screen all okay now? Fantastic. So let me just get organised here. So first of all, thank you very much to everyone for coming along tonight. It's a bit of a cold evening and my talk's titled, It's My Sinus Doctor. We've all heard that phrase before. Sometimes it's a welcoming phrase, but sometimes it's not. So I just wanted to give you a bit of an overview of what we'll talk about tonight. We'll talk a little bit about anatomy, physiology, and then we'll focus on rhinosinusitis, which, as we know, can be divided into acute and chronic. And really the crux of this talk is on chronic rhinosinusitis. And then if we get time, there's some extra things that I'm happy to talk about, or some other topics such as lack of smell, trauma to the nose, and epistaxis. So it's all pretty basic. As we know, the nose is divided into right and left nostrils by a midline structure called the septum. And then we have these filters within the nose called the turbinates. We have the inferior turbinate, the middle turbinate, and the superior turbinate. And there are certain structures that drain into each of these regions. Into the inferior meatus, the nasolacrimal duct drains, whereas into the middle meatus here, this is where the majority of the sinuses drain. At the top of the nose, obviously, we have the olfactory cleft region. When we look into the nose with an endoscope, this is within the right nostril. This is going from the front of the nose and working backwards or posteriorly, I guess. This is the inferior turbinate. This is where the nasolacrimal duct drains. This would be the middle turbinate. And this is the region where the majority of the sinuses drain, the maxillary, the ethmoid, and the frontal sinus. And then further back in the nose, this is the superior turbinate, and this is an opening to the sphenoid sinus. So this is all normal anatomy. It's all pretty basic. We have 4 sinuses. We have the frontal sinus located over the forehead. This is a coronal CT scan. So this is the septum, this is the inferior turbinate here. And this is a coronal scan done slightly more posteriorly. And this is the ethmoid sinuses here. This is the middle turbinate, and this is the maxillary sinus. And then further back in the nose, you have the sphenoid sinus. And in broad terms, the sinuses should be filled with air, and on a scan, black is good, whereas thickening or a polyp or mucus or growth or whatever it may be is grey. So on a CT scan, you only get three colours. You get white, grey and black. Within the sinuses, they secrete mucus, and that mucus beats towards the natural opening, and that's done with the aid of cilia. So in simple terms, some sort of blockage to the natural opening can lead to stasis, which then leads to inflammation. And also within this concept is that creating accessory openings is not helpful. There's a concept of defense versus disease, and that consists of our immune system with three basic components. We have mucociliary clearance, which requires functioning cilia. Then we have innate immunity, such as lysosomes. And then we have acquired immunity, which consists of humoral and cellular component. And I guess this B lymphocytes and the production of antibiotics is all very relevant with COVID-19 and vaccination response. So we've already covered some anatomy and physiology. I'm just keeping an eye on the time. So what's sinusitis? Well, sinusitis is really a complex inflammatory response involving the mucous membranes of the nasal cavity and paranasal sinuses. It's not simply an infectious process or an anatomical problem. And the real term is actually rhinosinusitis because it involves both the nose and the sinuses. And in broad terms, sinusitis is divided into acute and chronic. Depending on which journal or body that you listen to, acute rhinosinusitis is either defined as less than 4 weeks or less than 12 weeks. So I think just to keep things simple, acute rhinosinusitis is less than 12 weeks and chronic rhinosinusitis is greater than 12 weeks. And throughout this talk, I'll often just shorten the word rhinosinusitis to sinusitis just to keep things simple. And chronic sinusitis is broadly divided into two categories. Those without polyps, which is probably more common than those with polyps. I'm not really going to focus on acute rhinosinusitis during this talk, and I said the health pathways that Lena showed you, I think they're fantastic. I think they're very accurate, and I think they're a great resource. So acute rhinosinusitis is divided into viral acute, which is the common cold. It can be also categorized into post-viral acute rhinosinusitis and acute bacterial rhinosinusitis. And the typical organisms, strep pneumonia, Haemophilus influenza, and Moraxella catarrhalis. And treatment consists of a range of options, starting with analgesia, saline irrigations, whether that's your classical sinus rinse bottle that we all have that is very effective, to using saline sprays such as Fespray. Nasal decongestant sprays obviously have to be wary of prolonged use of them, anywhere less than maybe 3 days. And then use of, in addition to saline irrigations, nasal decongestant sprays, then you can also add in a topical steroid spray, and as well as your choice of antibiotic, and there's 3 antibiotics listed there. So that's all I'm going to really say about acute rhinosinusitis. I'm going to now focus on chronic rhinosinusitis. So what are the causes of chronic rhinosinusitis? Well, hay fever or allergic rhinitis, which can obviously be seasonal or perennial, may occur after a viral upper respiratory tract infection. I'm sure we're all aware of that, where we developed a cold and then we don't really get better. And then it leads to ongoing congestion and postnasal drip, and then on and on it goes, and usually it resolves, but not always. Anything that causes inflammation, such as a prolonged use of nasal decongestant sprays, also a predisposing factor. Immunodeficiencies. So that's not that common, but people might have a history of unusual infections or recurrent pneumonias. That might give you an idea that perhaps this person's got an underlying immunodeficiency. People can have mucociliary disorders, cystic fibrosis. There's a unified airway theory with regards to the upper and the lower airway. So often there's an association between adult onset asthma and chronic rhinosinusitis. Dental problems can be a predisposing factor. Bacterial biofilms and superantigens get quite a bit of attention in research journals, which I'll briefly mention in the next slide as to why. With regards to the physiology, I just talked about the concept of the cilia beating towards the natural ostium, and so any sort of blockage to the natural drainage pathway, such as a polyp, can cause blockage and congestion. And other factors might include smoking, irritants, and pollutants. So what are biofilms? What are superantigens? Biofilms consists of bacteria in a polysaccharide mix, and in this form, they evade the host defences and they render antibiotics ineffective. Staph aureus, for example, produces superantigens, and they cause cross-linking between antigen-presenting cells and T lymphocytes, further causing an inflammatory response. So there's this concept of something causes inflammation, maybe something, and that then leads to some sort of obstruction, which then perhaps causes a secondary bacterial infection. And so you get this circadian effect of one leads to the other. The underlying principle, however, is that it's an inflammatory response rather than an infective response. So in this series of scans here, you have someone with a healthy left maxillary sinus. They perhaps develop a cold. You get some edema here. The drainage pathway then becomes obstructed. You can't drain, and then it leads to a secondary infection. Excuse me. So what are the symptoms of chronic rhinosinusitis? It's all pretty basic stuff, but they include the following: nasal discharge, whether it's out the front of the nose or down the back of the nose, nasal blockage or congestion, loss of smell, facial pressure or pain. So we often see the patient who comes to us, doc, it's my sinus, it's playing up. And in kids, they may also have a cough. And there are other symptoms such as headaches, halitosis, fatigue, and dental pain, and so forth. On a simplistic term, people, when they have a blocked maxillary sinus, they will complain of cheek pain, or if they have ethmoid sinusitis, then they might complain of pain between their eyes. Frontal sinus, people will complain of pain referred to their forehead, whereas people with sphenoid sinusitis, they might get vertex pain. But in the majority of cases, sinusitis is not confined to one sinus, so that needs to be considered. How do we examine people's noses? The simplest way is possibly to use an otoscope, or you can use a headlight with magnification. So this is typically what I might use with a battery supply, and I put it on my head and keeps me hands-free, so it will look something like this. It's got a light, and that's very useful for me to be able to have a look and show and have an appropriate examination. In addition, we also use specialised endoscopes, and this enables a more detailed evaluation posteriorly in the nose. And I have a situation where I have a monitor, and it's great to be able to show patients what's going on inside the nose. So when you first look inside the nose, if you're lucky, you might see inferior turbinate. Sometimes inferior turbinate gets confused with a nasal polyp. Just checking the time. But with endoscopes, we can see the inferior turbinate and the middle turbinate. And then if we sneak our telescope or our endoscope in further around the corner, then all of a sudden we might see something that resembles mucopus. And so just on this, if we were to take a swab of someone's mucopus, which is perhaps a bit of a controversial point, it's much better to take a swab of mucopus rather than a swab of someone's nose who's will be colonised with Staph aureus, for example. Or we might see polyps inside someone's nose. Lena was talking about red flags. So what are the red flags that we need to be aware of? Well, people with severe symptoms, people who are systemically unwell, people with severe frontal headaches, orbital signs such as cellulitis and double vision, cerebral signs. And these two, orbital signs and cerebral signs are quite rare, but that's why they are red flags. And anything that might suggest some sort of malignancy, which is typically unilateral symptoms such as a bloody discharge and rarely facial paresthesia. What are the complications of chronic rhinosinusitis? Well, a bit like the red flags, they can divide into orbital and intracranial. On this slide here, someone's developed a subperiosteal abscess. But technically they're named preseptal inflammation, orbital cellulitis with subperiosteal abscess, orbital cellulitis with orbital abscess, and cavernous sinus thrombosis. So these things are rare. This shows an unfortunate situation where the sinusitis has spread intracranial. This is extremely rare, but you can get meningitis, subdural abscess, epidural abscess, brain abscess, and cavernous sinus thrombosis. And rarely people can get something called a mucocele, where they get obstructions, in this example, to someone's ethmoid sinus. And as it continues to secrete mucus, it slowly creates pressure and expansile effect, and it pushes on someone's eye, and they might present with, heaven forbid, double vision. Again, these things are rare. What about the typical person who comes to us with sinusitis? So they think they've got sinusitis. So how do we evaluate these people? Well, I like to keep things basic. We take a history, we examine people, we do investigations where appropriate, and then we have a treatment plan. So when should we order a CT scan of the sinuses? Well, generally you should order a scan when you're unsure of the diagnosis. Maybe there's some red flags going on. But if someone comes to you with the initial symptoms of blockage, congestion, you don't need to do a CT scan. You will just go on and treat the patient with some steroid sprays, for example. But then they will come back to you, and then you might do something else, and they'll come back to you. And then at some stage you go, they're not really responding, so perhaps I should then do a CT scan. We always do a CT scan when we're planning for surgery. We no longer really do plain X-ray. Well, we don't, let's be clear about it, we don't do plain sinus X-rays. The information that we get from them is far inferior from a CT compared to a CT scan, and MRI scans are rarely required. We really just do that if we're perhaps thinking about unusual causes to help make a differential diagnosis, or perhaps for staging if they've got some sort of a sinonasal malignancy, which would be very rare. So this is a typical CT scan of someone who's got chronic rhinosinusitis. This is the right eye, this is the brain, this is the septum, which is slightly deviated to the right. This is the inferior turbinate, this would be the middle turbinate here, but it's really hard to see the differentiation between the middle turbinate and the sinus blockage. So these are the ethmoid sinuses, this is the maxillary sinus, and all I can really say is that it's opacified. And this opacification could be due to pus, could be an infective process. There could be some polyps in there as well, and there could also be some mucus. The scan's not smart enough to differentiate between the underlying pathological processes.
Sorry, Chris, I might interrupt you. Julia wants to know, how much radiation does the CT scan of the sinuses sort of
the CT scans done nowadays, the amount of radiation is extremely low. So I think when patients are concerned about radiation exposure, I think they can generally be reassured that the newer scans are very low in terms of radiation exposure. Some people relate it to an international flight, for example.
Thanks.
We briefly talked about swabs before. I had a phase when I used to do swabs, but to be honest, they don't really change by and large, they do not change my management. I haven't found them very useful, and that's the recommendations of current publications, which is mentioned in the health share pathway. You might do a swab if they're not responding to medical therapy. Sometimes you might get some pressure from the patient that, how do you know that they're not on the right antibiotic? But it's very difficult to visualize pus and to take a swab at the same time. So if you just put a swab in the nose, well, it's going to grow Staph aureus. I've got Staph aureus in my nose like everybody else. So I think swabs generally have a minimal role to play. What is important to think about related conditions, excuse me, such as typically allergy disorders or less frequently immunological disorders. If they've got severe allergic symptoms, you might involve an allergist, and I have a good relationship with several allergists in Melbourne. You can either order a RAS test or skin prick test can be ordered. And in broad terms, I think allergy conditions are clearly best managed by an allergist. If they've only got minor allergy, well then, you perhaps have that discussion, whereas if they've got severe allergic type symptoms, well then obviously involving an allergist would be appropriate. And then you may do some sort of immunodeficiency, and again, allergists, immunologists work well, are our helpful friends. What's the criteria for the diagnosis of CRS? It's stipulated we have position papers, and there's been one that's come out recently in 2021 from the American Academy, and it's a combination of symptoms and signs or investigations. So they need to have 2 or more of the following symptoms. So it's not one symptom, it's not just facial pain or headaches. Nasal discharge, nasal obstruction, hyposmia, facial pressure or pain and cough in kids. And also they need to have evidence of inflammation on nasal endoscopy or an abnormal CT scan or evidence of purulence. So it's really 2 symptoms as a minimum and 1 other finding, either an examination or investigation. So we all get the patient that comes to us and they're complaining of sinus headaches, and you're not too sure whether they've got sinusitis, but they tell you it's their sinus headaches. If that's the first thing they say to you when they walk into the door and they say, I've got sinus headaches, 99 times out of 100, they have not got sinusitis. Have you got congestion, postnasal drip, poor smell? No. You examine their nose, there's no inflammation, there's no mucopus, there's no polyps, and you do a CT scan and it's normal. So if they first complain about sinus headaches or sinus pain, the majority of the times it's not sinusitis. And that goes back to the criteria for the diagnosis. They need to have 2 or more symptoms plus another finding. They might have migraines, cluster headaches, tension headaches, for example. Excuse me. Other things that might be something unusual like a fungal ball, and typically you see double densities within the sinuses here, and antifungal agents don't have a role in that. Could be some sort of a tumour. Again, this is rare, unlikely, but they have atypical features. So that's a consideration for differential diagnosis. What about management? Well, it's not that difficult. We all know these things. This basically consists of saline douching, or there are many different brands that are out there. I like this brand, no conflicts of interest, but I like the smooth top. But the main thing is to get them to use it. Topical steroids, oral antibiotics is an option. The role of antibiotics is a little bit controversial, but I think it's entirely appropriate to consider that and think about underlying causes. So nasal irrigations are simple, safe, effective, and have minimal side effects. How do they work? Simply remove mucus, so possibly remove antigenic proteins, and they help with ciliary beat frequency. I just get my patients to either use the salt sachets or get a 1/2 to 1 teaspoon of salt and put it in the rinse bottle and tell them to add some warm water to it. Whether the water should be sterile or not is probably not a big deal. Melbourne tap water is very safe. Whether you use cooking salt, table salt, or rock salt, I don't think it really much matters, but table salt's got a few other additives to it, so I typically say cooking salt. But there are different ways of doing it. I think the best thing is to get them to do it and keep it simple. You can add things to your rinse bottle. You might have heard of unusual things like baby shampoo, antibacterial, so that's a no-no. There's something called xylitol, but these things the research supporting these does not stack up. So I just say 1/2 teaspoon of salt to 1 teaspoon of salt with 1 cup of water, and I can even do it in the shower. You hear of some people buying some expensive commercial packages, and I think that's unfortunate. So what about nasal steroid sprays? Well, that's should be recommended. Tell them that there's some delay in onset of action. I advise patients not to aim towards the midline because you'll hit the septum. So I might say a crossover technique, opposite hand to opposite nostril, or aim towards the top of your ear. Whether you put the head forward or the head back, I don't think it's important. I just say in a neutral position. How long should you do it for? I think a month is reasonable. And obviously the patient needs to be compliant with it. There's various brands that are available. I don't have a particular leaning towards one particular brand, but here's some brands here. This is from perhaps the older to the newer. Maybe if they've got significant hay fever, there's some advantage of using a combination spray, an antihistamine and a steroid spray. Some people might use Cuva inhaler with a baby teat. That's one option. But there's been, over the last few years, there's been a push or a move perhaps towards trialling Pulmocort respials, which are traditionally used for people with asthma. It can either be 0.5 or 1 milligram per mil. So I just get them to add that to the saline rinse bottle. So still put your salt in, still fill it up with warm water and just add this in and do that once a day. So that's another option of getting sprays or getting some sort of steroid inside your nose. And putting a steroid in a rinse bottle, obviously it will penetrate further. What about oral
Chris, sorry, Chris, I'll just interrupt you. The question about whether the saline douching, is that just douching the nasal passages or actually going into the sinus?
If they haven't had surgery, a little bit will get into the sinuses. There are little nooks and crannies. So yes, it will get around into the maxillary and the ethmoid sinuses. It will struggle to get into the frontal sinus. If they've had surgery, well then obviously when things have been opened up, then obviously the penetration will be greater. So everything's got its,
Is the purpose to get rid of mucus or to unblock the ostia?
Well, it's really to help get rid of mucus, to help get rid of mucopus that's there. And also it enables them, when you use a nasal steroid spray, to land directly on the mucosa and have greater penetration and greater effect.
Yeah, great.
I think it's a very simple thing, and I think it's very effective. What about oral antibiotics? They're frequently used in chronic rhinosinusitis. It's there is an infectious component, so in principle it makes logical sense to use it, and I do use antibiotics, but the evidence to support the use of antibiotics is controversial. I think in the health pathways it recommends using it if they haven't responded to saline irrigations and a nasal steroid spray. I tend to use roxithromycin or doxycycline. How long do you give it for? Anywhere from weeks to months. I think giving it for a month would be a reasonable thing. I tend to use roxithromycin because it both has an anti-infective effect as well as an anti-inflammatory effect. And also involved in your management is to think about underlying causes, which I briefly mentioned before. So if they've got significant hay fever, then an avoidance where possible, but that's easier said than done. Sprays and antihistamines and immunotherapy, which is obviously done under the care of an allergist immunologist. There are many other things. It's 7:35, so just keeping conscious of the time. There are many other things you can do. Their benefit is dubious, but we shouldn't be using decongestant sprays or tablets, mucolytics, antihistamines, other sprays. There's some talk about using surfactants, manuka honey, capsaicin, baby shampoo, etc. The evidence to support those does not exist, but you'll come across those. And I guess part of the reason why they exist is because managing sinusitis is a difficult thing, and as we know that not always saline douching, steroid sprays and antibiotics work, and so patients get frustrated and they look elsewhere or they come to you for further options. So you've just got to stick to to what we know and tell them what's supported by research and what's not. A subgroup of patients have nasal polyps, so that's chronic rhinosinusitis with nasal polyps. These patients typically present with nasal obstruction and smell. So in this, so you still do your nasal douching, you would still do your nasal steroid sprays, but yeah, I think it's entirely appropriate to have a trial of prednisolone. There's different ways of giving prednisolone. I typically give 25 milligrams for 5 days and then stop it. You can give 50 for 3, 25 for 3, 12.5 for 3 days, or whatever works best for you. As I said, I do 25 for 5 days. You talked about the side effects, diabetic, reflux, trouble sleeping at night time, psychotic events, osteoporosis, effects upon the eyes. So like all things, you've got to give patients information, but put it in context. So, but prednisolone is very effective with people with nasal polyps. I would feel reasonable comfortable giving it maybe twice a year. But I think you just got to be a little bit, you've got to pick your patients that have got hypertension, reflux, diabetes. Well, maybe it's not so good in those patients. Sometimes I use Montelukast, singular, 10 milligrams daily. There's some people that seems to work. Some people have nasal polyps and asthma and aspirin sensitivity, which is a triad, often called aspirin exacerbated respiratory disease. These people have worse disease. They tend to have more relapsing of their nasal polyps. These patients often managed conjointly with allergists and immunologists because their asthma is unstable. Aspirin desensitization, that's typically has gone out of vogue. People have tried to do it through the Alfred Hospital, through the Allergy Immunology Department, which is actually where I used to work. But telling someone that they're allergic to aspirin and giving them aspirin, that's some people are not too keen on that. And there's evolving use of monoclonal antibiotics, which I think that's an exciting thing. But currently it's only approved for people with severe asthma or unstable asthma. That's where the allergists come into it. But this is an evolving space, and I've seen some patients who've had very good results who've been on it, and it's helped their nose.
Sorry, before you go on, Chris, can I just ask you about that slide? So I had 2 questions. One was, with the use of Montelukast, how long are you expecting to use that for?
So typically I give 10 milligrams a day for 30 days, and then I would say to the patient, it's a trial, and I'd say to the patient, give it a go for 30 days. If you find it useful, then that would be, stay on it. If you don't find it useful, then stop it.
Okay. So, and are you actually resolving the polyps, or are we just sort of making them not so symptomatic?
To be honest, probably not making them less symptomatic. So polyps are divided into grade 1s, 2 and 3. So, I'd see grade 1 polyps as opposed to grade 3. But no, I don't. It's not common that the polyps have gone completely. Mm-hmm. So the problem is they still have that underlying inflammatory effect. Surgery, I don't really want to talk too much about surgery, despite me being a surgeon. When do we do surgery? It's really reserved. Well, it is reserved for those people who have had appropriate medical treatment and not responding. And that's what's appropriate medical treatment can be highly variable between one patient to another. Some people say they never want to have surgery. Some people know people who've had treatment for nasal polyps and they say, oh, my polyps come back, or my neighbour had it. So you get a varying response to those people, to people when you talk to them about it. But like I always say, we do simple things before complicated things. We do medical treatment before surgical treatment. We used to say failed maximal medical therapy was when we would consider surgery, but now there's been a slight change in the terminology where they've had appropriate medical treatment. And so that's, I guess, those saline irrigations and some sort of a nasal steroid spray for a minimum of a month, and it would be reasonable to have a course of antibiotics. What's functional endoscopic sinus surgery? Involves the placement of minimally invasive endoscopes instruments into the nose to open and drain and ventilate the sinuses whilst preserving normal sinus tissue. If you've got some time, I've got some videos to show you. The aim is to restore mucosal disease, and also enables post-surgery the ability to then install our nasal sprays or even our Pulmocort respirables in our saline rinse bottle, so it achieves greater penetration, because the underlying thing is an inflammatory process. So You know, I always say that it's not just surgery; it requires ongoing medical treatment as well. How with surgery? Yeah.
So, Chris, I just wanted to make a comment. That's really interesting to hear you say that, because I really think that there is a misconception, in particular among patients, that surgery is to cure their disease, and then they get upset when it comes back. So it's great that you're explaining to them, you know, this is an ongoing chronic disease, but I'm not sure that everyone is aware of that. So it's obviously our job as GPs to follow that up with the ongoing message that, yeah, now you've got to keep going on your maintenance and suppression. Yes,
very much so. And now we do lots of things as day case with dissolving sponges. So that's really what I wanted to say to you about chronic rhinosinusitis. I've got some other things I can show you, but chronic rhinosinusitis consists of at least 12 weeks of symptoms. Medical therapy consists of saline douching, nasal steroids, and it's entirely reasonable to use some oral antibiotics. And consider CT scanning those patients not responding to medical treatment or when the diagnosis is unclear. So what I might do at this stage, let's just see how I go. I've got some extra topics to possibly briefly go through, but I just want to show you a couple of videos. Let's see how we go here.
Chris, while you're doing that, there's a few questions. Can you multitask this?
Yeah.
So a couple of quick ones, just going back. Does CT sinus involve any IV contrast?
Oh, no, we don't. No, we don't give IV contrast for a CT scan of the sinuses.
Yeah, and with regard to swabbing, do you think it's important to swab the very back of the nasopharynx like we do for viral swab?
No, I would.
It really has to be under vision.
In my opinion, the only useful swab is that of pus, and it really needs to be pus visualized. So that's not that common, to be honest. Like, it might be contained within the sinuses, not coming out into the nose. But if you just put a swab into the nasopharynx or into your nose, I don't think that's helpful, because it's just going to grow Staph aureus, and it's just going to complicate the issue. And the patient will see this result. It says, I've got Staph aureus in my nose. And then you've got to educate the patient that if you take a swab of my nose, that's what I say, the patient's going to grow Staph aureus. So I think sometimes it can be misleading and actually unhelpful.
And there's a couple of questions about the Pulmocort respials. Can we use them long term? Are there any potential side effects?
Like all things, it's of the same grouping as within nasal steroid sprays. So they've looked at the hypothalamic pituitary axis, and they show there's no long-term suppression, and they're safe to use long-term. So long-term, I'm very comfortable for people to use them for 2 years, put it that way. If indefinitely, as long as you're happy to use them, a nasal steroid spray. So it's an option. So obviously they don't do a steroid spray plus the Pulmocort respials. It's one or the other.
Yes. So, and can you re-explain, I know you did explain this, but how do we advise them to use the Pulmocort respial in the rinse bottle?
Yeah, so they just still make up the rinse bottle like they would normally, and they just add the Pulmocort respial. So this is exactly what I say to the patient. 1/2 to 1 teaspoon of cooking salt, fill it up with warm water, tear the ampoule, the top off, pour it into the rinse bottle. So now it's got salt, water, Pulmocort respials, and douche your nose. And how do I tell them to douche your nose? Over a bathroom basin, put up against your nostril and say "ker, ker." Why do I get them to say "ker, ker"? Because that lifts up the uvula, acts as a trapdoor so it doesn't go into their throat. And this is actually what I do to the patient. I say, if you just do this, it'll go down into your throat and you'll cough and splutter. So just go "ker, ker, ker, ker." And in addition, I might say, more of those people who've had surgery, put the salt in, put it in your bathroom. When you have a shower, take it into the shower with the salt with you. Just hold it up against the rose of the shower, fill it up with warm water, make a mess in the shower. It's very simple, it's very safe. You know, you're trying to get someone to boil the water, then put it in the fridge, and then put it in the microwave. It's too cold, it's too hot, on and on it goes.
Yeah, great. And you did mention this, that how often per day should patients be using the nasal douche?
In principle, once a day. I'm a big fan of doing things once a day, whether it's steroid sprays, douching, antibiotics. That's why I like roxithromycin. But I also say to my patients, I might say, how many times can you go in the surf? You can go in the water as many times a day as you like. So I said, if you want to do it 3 times a day. Sometimes I also might say is clean your teeth, clean your nose.
Yeah. Great. I think that's all the questions. Keep going, please.
So let's just see how we go with a couple of videos. I'm just filling my way here. This is someone who's got, so it's a very 5-second video. This is a time of surgery. So this is a sucker going to someone's left maxillary sinus, and that's just what typical mucopus might look like. So you open these things up, and then you can imagine post-operatively when they're douching their nose with the Pulmocort respules, it now goes into their sinus. So this is normally covered over by a anatomical structure. Whereas that's the typical bacterial infection. So as opposed to something that is less common, but we talked about differential diagnosis, people can get fungal sinusitis. So this is what fungal debris might look like. And it's a different consistency. So these, again, very short videos. Another video just to show you. This is talking a little bit about, it's 7:48 too, by the way. Someone had previous surgery, but the natural ostium was not open. And so here there's pus. And we talked about accessory openings in the sinuses, particularly maxillary sinus, likes one sinus to open up. So you're sucking away the pus. They've had previous surgery before, they're still struggling. And then all of a sudden, you see that there's a little bridge of tissue here. And so sinuses, particularly maxillary sinus, don't like these accessory ostiums. The mucus goes round and round and gets trapped. So we simply divide that. But that's an example of recirculation. I'm going to show you an unfortunate video, not a good one from a surgeon to show, but anyway. We used to be too aggressive with our surgery. We'd strip out all the structures within the nose because we thought that would help people. And we would significantly, perhaps when I was training or before I was training, would remove their turbinates too aggressively, and the nose then became unhappy, and it responded by forming all this crossing inside the nose. And so, like all things, you know, our body is very well designed. So we've all heard these horror stories. So now we're a lot more cautious or minimally invasive, let's put it that way. So I think that seemed to work okay, those videos. So what I might do at 7:49, I might just run through in very quickly a couple of other topics, if that's okay. And then I think we'll call it a night. So
just also while you're doing that, a couple of questions. What's the age cutoff definition? Can young people have the same definitions for acute and chronic?
Yes, so it's still, well, acute tradition has been less than 4 weeks and chronic's 12 weeks or longer. So yeah, whether you're pediatrics or adults.
But kids can get sinusitis. Is there an age cutoff?
Well, okay. I think anyone under, you know, if someone comes to you with sinusitis and they're 10, obviously, I mean, as they develop, the sinuses expand into their sinuses. So it's really more adolescents as opposed to, you know, children under 5, obviously, put it that way.
Okay.
I'm very reluctant to operate on people's sinuses when they're kids. They're growing, yeah. By the way, I should say thank you to everyone for attending tonight, and to Lena for organising this, and also to Karen Baker. So what I'm going to do is very quickly run through some slides. It's 10 to 8. There's 4, rarely people can have fungal sinusitis. There's 4 sorts. There's a fungal ball, or fungal mycetoma, but correctly it's a fungal ball. A fungal ball is one-sided, and they get these double densities. We don't really know why it occurs. Why does it occur on one side and not the other side? Why does it occur typically as it does? We don't know. Maybe they've been sniffing fertilizer or something like that. Maybe there's some sort of autoimmune response, but they get these typical double densities. You can also get people with allergic fungal sinusitis, which is often one-sided with nasal polyps. And you go in there and they get this thick, sticky mucin, and these people tend to relapse. And they require oral steroids. And then you get the very rare acute invasive fungal sinusitis. And when I was in the United States, I saw an undiagnosed diabetic who unfortunately presented with rapidly progressing, and he spread into his brain, and he had his eye removed, and he unfortunately ended up dying from his acute invasive fungal sinusitis. So, you know, red flags, people are systemically unwell. Rare things do happen, rarely, thankfully. What about smell, loss of smell? Physiology is to do with perception, or people often say they can't taste, and really what they mean is they can't smell. Because you say, oh, if I put some sugar on your tongue, can you taste that? Do you know it's sweet? If I put some salt on your tongue, do you know that it's salty? And they go, oh yeah. If I give you some lemon juice, they go, oh yeah. So flavour is a combination of smell and taste. So often when they say they can't taste, what that really means is they can't smell. There's a function to smell, as listed here. The smell region is at the top of our nose, the olfactory cleft. Anosmia is a complete inability to smell. Hyposmia is decreased ability to smell. And then there's other names here. So phantosmia is a bit like a phantom limb, but where there's no odorant in the room, but they can smell something, and often a terrible, disgusting fecal smell. So this is very rare. Most people present with anosmia or hyposmia. The etiology can be thought about in terms of the pathway of odorants, something within the nose, such as sinusitis or nasal polyps. Viral, that's all very topical with COVID-19, or they might typically occurs in females. They had a cold 3 years ago, and then the cold didn't resolve, but they just couldn't smell. So that's pretty typical of a viral-induced loss of smell. This is rare, but it attacks these little olfactory filaments here. A head injury where there's shearing forces, and extremely rarely can be intracranial. So if they've got paresthesia and they've got loss of smell, then you probably should do an MRI scan of their head. How do we assess it? There's different ways of assessing it. We have these scratch and sniff tests. And how do you treat it? Well, like all things, treat the underlying cause. Sometimes we can give prednisolone. That's more for sinonasal problems. And then there's this concept which I think is very good. That's of olfactory retraining. Our brains are pliable, and I'd suggest that you tell your patients who can't smell, go and sniff the roses, eucalyptus, lemon, and cloves to try and stimulate our olfactory nerves. And if they live on their own, they need to make sure, well, regardless of whether they live on their own, but if they live on their own, you've got to be careful that their fire alarms are working, because they don't want to burn some toast and not know about it. You might even swap from gas stoves to electrical stoves, and you've got to make sure you have someone checking the fridge for the milk. We've got 5 more minutes and then we're done. What about trauma? Fractured nose needs to be fixed within 3 weeks. Rather than get a septal hematoma. The septal hematoma, you might see some bogginess within the nose, and that requires surgical drain. Very quickly, as you can see, moving on to epistaxis. That's divided into the front and the back part of the nose. You have Little's area here at the front. Depends upon the age and where it's bleeding from, how bad it is. They could be an elderly lady on aspirin. You might think about the underlying, their overall status. If it's bad, they'll go to the emergency department. We've got a great emergency department at the Eye and Ear Hospital. You generally want to obviously treat the side that's bleeding, but if someone's heavily bleeding, you might get them to lean forward. Silver nitrate sticks on Little's area. Don't do it too aggressively, because you don't want to cause a septal perforation. I will not cauterize the same. I won't cauterize both nostrils at one sitting. I'll make them come back. There are varying packs you can put inside the nose, and you can do surgery. And the very last thing I wanted to talk about was a little bit of research that I did in the United States on rabbits. We unfortunately gave these rabbits some Pseudomonas. We injected Pseudomonas into them, and we gave them sinusitis, and then we did some further evaluations of their sinuses. And what we actually did was we installed a natural sugar called xylitol, which is thought to upregulate the antimicrobial factors. And so we did a control of xylitol with Pseudomonas versus saline with Pseudomonas. And what we found was that when we use xylitol, there's a reduction in the amount of Pseudomonas that we recovered. So we've got so many things to learn about things in medicine, including sinusitis. So so I'm a big fan of research and keeping up to date. So that's all I wanted to say. I think it's 4 minutes to 8. I said I wouldn't go over time, so I'll pass it back to Lena and say thank you very much to everyone for attending tonight.
Thanks so much, Chris. Have you stopped sharing?
Shall I stop sharing? Okay.
Yep. And I will just share my screen.
I'm happy to take any questions, of course, or anything like that at all.
So yeah, evaluation form, just reminders that evaluation forms, a link will be sent to you at the close of this meeting. If you're not already on my mailing list, then please email me at gpliaison@inu.org.au and I'll add you to my emailing list. They're the main things that I'll email when the video recording becomes available. So thank you so much to our speaker, Dr. Chris Brown, for great presentations. Also, thank you to Northwest Melbourne PHN for all of your support in bringing you this webinar and for all your ongoing support for our GP education program. Thank you all you guys for attending and participating. I'll just check, Chris, if there's any further questions. Chat. Oh, there's a few questions there. Fungal sinusitis. What symptoms will make GPs think about fungal sinusitis?
Unfortunately, probably those patients not responding to appropriate medical treatment. So that would be the most common ones, to be honest, is a fungal ball, and I guess that's unilateral. So fungal balls are unilateral, so they may have some sort of unilateral symptoms. So that you would go, well, this is unilateral, this is not quite right. So therefore, then you would order a CT scan, and then the CT scan picks it up. So for fungal balls, there's nothing really in the history that tells you that they've got a fungal ball. It's really a CT scan diagnosis. With allergic fungal sinusitis, again, they'll be unilateral. So you do a CT scan, it becomes unilateral initially, and then it becomes bilateral. So again, you'd have a unilateral history. You do a scan, you'll show something that's unilateral, and you go, oh, this is not quite right. You then might have referred them on because they haven't responded to your medical treatment. And then at the time of surgery, biopsies would be done, and it would then confirm that it's a fungal process. So often they don't really present to us with symptoms and signs that staring at us in the face that say this is fungus. I guess there's a very extreme example of the unstable diabetic, newly diagnosed diabetic, immunocompromised person where they have a rapidly downward trend. So that would, then you might think of acute invasive, but that's very rare. Yeah.
The clue is that essentially they're just not responding to treatment, and so then the next step is to image them, and that's how it'll be picked up.
Yes.
Is the nasal septal hematoma always seen when you examine the patient?
No, you can get varying amounts of septal hematoma. They've knocked their nose, and they will come to you, or they've had some trauma to the nose, and they will typically say that they cannot breathe through each nostril, or both nostrils are blocked. But generally speaking, you look inside the nose and you'll see something pretty obvious. You won't be able to see through their nasal caliber, and it's anterior. So yes, it is significant, and you should be able to see it with using either with an otoscope. It's not, you don't need specialized instruments to see a septal hematoma. It's at the front of the nose, and the patients are telling you that they're getting worse, and their blockage is getting worse in the setting of recent trauma.
Okay, great. And one last question. Are there other specific treatments for biofilm?
Unfortunately not. That's why we do research. There was a thought that you could possibly break up these biofilms. I mean, why do we use shampoo in our hair? You know, maybe to break down the oils in our hair. So this was one of the theories that maybe you could use put a couple of drops of baby shampoo in your saline rinse bottle. So that was a vogue at one stage. So trying to break down these biofilms is not easy. And so that's part of the reason why you give people antibiotics and they don't respond, because there's an underlying inflammatory process going on, and biofilms are a difficult thing to overcome.
Great. Well, thank you so much. I think that's all the questions. If participants can have a look in the chat box, Northwest Melbourne PHN have posted the link to the SurveyMonkey for evaluation, and so you can get your points. So I think if you click on that, that'll be the best way to answer that now. Any final comments, Chris?
Thank you to yourself and to everyone for attending.
Oh, thank you so much. All right, so I'm going to leave us there just with the link so that you can click on it for a little bit. I'm not sure if it'll come up after the meeting closes as well. I hope it does. All right, thanks everyone for attending.